picture this. You are in agonizing, unrelenting pain.
Right.
And it's 2 o'clock in the morning. It's, the kind of pain that just sits heavy in your bones.
Oh, yeah.
Radiating out, wrapping around your chest until you feel like you honestly can't even draw a full breath.
It's terrifying.
Right. You can't think. You certainly can't sleep. The darkness of your bedroom just feels, well, suffocating.
Mm-hmm.
And the prospect of waiting until Monday morning to call a primary care clinic, it feels entirely impossible.
Because you need help right now.
Exactly.
Yeah.
So you do what society has trained you to do since you were literally a child. You go to the one place built for emergencies.
The ER.
You go to the ER.
It is, it's the universal safety net, really.
Yeah, exactly. You pull up to those automatic sliding glass doors, bathed in that harsh fluorescent light, and you're expecting relief.
Or at least a path to it.
Right, at the very least. But what actually happens when you walk through those doors?
It's rarely what you hope for.
No, the reality hits you like a wall. You find this totally chaotic waiting area.
Yeah.
You hear machines beeping, phones ringing, people rushing past you with this frantic purpose that, entirely excludes you.
You're just another number.
Literally.
Yeah.
You take it. You sit in a hard plastic chair and you wait.
And wait.
You wait for 3 hours, maybe 5 hours, maybe 8. Every single minute dragging out while the cane just screams in your ear.
And the wait is just the beginning of the ordeal, really.
Right.
Yeah.
Because when your name is finally called and you finally get to see a doctor, the interaction is nothing like you hoped.
It's, it feels incredibly rushed.
So rushed. The doctor's glancing at a chart, glancing at a clock, maybe even looking back toward the hallway.
Yeah.
The attitude you get doesn't feel like this warm embrace of healing. I mean, it feels dismissive.
Sometimes even suspicious, honestly.
Yes, suspicious.
Yeah.
You're given a really brief physical assessment. Maybe they run a quick blood panel or do an x-ray just to make sure nothing is broken.
Right, checking the structural stuff.
But when the results come back clear, the tone shifts. You're given a minimal intervention, maybe a basic anti-inflammatory pill, and then you're just discharged.
Scent packing.
You walk back out those same sliding doors into the cold night air, feeling worse than when you arrived.
Because you feel judged.
Judged, completely invalidated.
Yeah.
You start to wonder if you're, actually going crazy.
And worst of all,
You are still in exactly the same agonizing pain.
yeah, it is a profoundly isolating experience. And the tragedy here is that for millions of people living with chronic pain, this isn't just, a bad night out.
Right.
It is an experience that happens over and over again. It becomes this relentless cycle of desperation and profound disappointment.
A completely vicious cycle.
It's a cycle that, frankly, the modern medical system has been incredibly slow to recognize and even slower to correct.
Which is exactly why we're diving so deeply into this today.
Yeah.
We've gathered a massive stack of source material for this deep dive, peer-reviewed medical journals, updated clinical guidelines, psychological reviews, and systemic healthcare analyses.
A lot of heavy reading.
So much reading. But we are going to explore this phenomenon, this devastating cycle, and we're calling it the Triage Trap.
I like that name for it.
Yeah, we want to look at the hard data to understand why the emergency room is biologically and structurally the absolute worst possible place you could go for chronic pain.
It really is.
We want to validate that intense frustration that you, or maybe someone you love, might be feeling right now.
It's a very real frustration.
And to do that, we have to uncover some truly mind-blowing biological differences between acute pain and chronic pain.
Because that's where the misunderstanding starts.
Exactly. Because if we want to understand why the system fails so spectacularly, we have to understand what the ER was actually built to do in the first place. Okay, let's unpack this.
So when we talk about the emergency room, we really have to acknowledge that it is an absolute triumph of modern medicine.
Oh, for sure.
The modern ER is a miracle of logistics and acute care, but it has a very specific, very narrow mandate, which is rapid stabilization.
Right.
The ER is designed to extinguish fires.
Like life or death situations.
Exactly. If you come in with a massive heart attack, a gunshot wound, or, a femur that has been shattered in a car accident, the ER is perfectly calibrated for you.
It's a well-oiled machine for that.
The entire system, the nurses, the techs, the physicians, the imaging machines, it's all built around assessing immediate life-threatening danger.
Right. They stabilize your vital signs, ensure your airway is open, stop the bleeding, and then either admit you for surgery or discharge you once that immediate threat is gone.
Exactly. It is a system built entirely, 100%, around acute trauma.
But chronic pain is not an acute emergency.
No, it's not.
And reading through this stack of research, that distinction is just so critical.
It's the whole ball game.
The source material makes it abundantly clear, right? Chronic pain is not just a prolonged symptom of an old injury.
It's not just an ankle sprain that's taking a really long time to feel better.
Right. It is a complex, distinct disease in its own right.
Let's break down the biology of that, because the distinction between acute and chronic pain is where the entire medical misunderstanding begins.
Yeah, let's get into the science of it.
So in the medical literature, acute pain is generally defined as pain lasting less than 1 to 3 months.
Okay.
But the time frame isn't actually the most important part. The key word here is protective.
Protective, meaning it serves a purpose.
Yes. Acute pain is physiological, it is highly adaptive, it is your body's vital, necessary warning signal that tissue injury has occurred.
Okay.
The scientific term for this is nociception.
Okay, nociception. Let's make sure we really understand that. Give me an example of nociception in action.
Sure. Imagine you are cooking in your kitchen and you accidentally touch a hot stove.
Ouch, yeah.
In a fraction of a second, specialized nerve endings in your skin, called nociceptors, detect that extreme damaging heat. They fire off an electrical signal that travels up your arm, into your spinal cord, and up to your brain.
All in like a millisecond.
Exactly.
Yeah.
Your brain processes that signal instantly and perceives it as sharp, intense pain.
Right.
The brain then sends a signal back down to your muscle saying, pull your hand away immediately.
So without that pain, I'd just leave my hand on the stove and burn down to the bone.
Precisely. Or consider appendicitis.
Oh, yeah, that's a good one.
That severe, crippling abdominal pain is a biological alarm bell. It is warning you that an internal organ is infected and about to rupture, and you need emergency surgery.
Wow, okay.
So acute pain has a massive evolutionary benefit. It forces you to protect the injured area, to stop using the broken leg, so that normal healing can take place.
And importantly, acute pain diminishes as the tissue heals, right?
Yes. Once the skin on your hand repairs or the appendix is removed, the pain goes away.
It does its job and leaves.
Exactly. Furthermore, it generally responds very well to standard medical treatments like painkillers or anti-inflammatories.
You know, I like to think about acute pain with a really simple analogy.
Let's hear it.
It is a highly functional smoke detector in your house.
Okay.
It detects a real fire in your kitchen. It's incredibly loud, it's super annoying, it hurts your ears, but it ultimately saves your life and your house.
That is the perfect way to look at it.
Yeah.
But chronic pain operates on a completely different biological mechanism.
Right.
The literature defines chronic pain as pain that persists beyond the normal healing time of the original injury.
Typically lasting longer than 3 to 6 months, right?
Right. But again, the time is just a marker. The crucial biological shift is this: chronic pain is pathological.
Pathological.
It is maladaptive. It has absolutely zero evolutionary benefit and serves no protective function whatsoever.
So going back to the analogy, well, if acute pain is a working smoke detector, chronic pain is a broken smoke detector with major wiring glitch.
Exactly.
It is blaring at 120 decibels at 3 in the morning.
Right.
It is waking up the whole neighborhood. It is causing you immense distress, but there is absolutely no smoke.
None at all.
There is no fire. The original fire was put out months ago. The alarm itself has become the primary problem.
And what is truly fascinating here, and what the newest medical literature is finally making clear to the broader medical community, is that this wiring glitch you're describing is not just a metaphor.
Wait, really?
It is a literal, physical, anatomical change in the human nervous system.
Hold on, literal changes. You mean the nerves themselves look different under a microscope?
Yes. The research shows that prolonged pain signaling actually results in deleterious pathophysiological changes to the body.
Wow. Let's walk through what happens.
Okay, so when those nociceptive signals, those initial danger messages from an injury, bombard the nervous system day after day, week after week,
Yeah.
the nervous system doesn't just get tired, it adapts. The neurons actually become hyperexcitable, they become sensitized.
Sensitized, meaning it takes less of a trigger to make them fire.
Exactly. The threshold for what causes pain drops dramatically.
Oh, I see.
The parts of the brain responsible for processing pain, specifically areas like the thalamus and the cerebral cortex, begin to amplify the incoming signals.
So it's like, imagine a soundboard.
Yeah.
Where a sound engineer just keeps pushing the volumes lighter up and up.
Yes. The brain gets so used to processing pain that it becomes hyper-perceptive to it.
Right.
It is constantly on high alert, scanning the body for threats, and misinterpreting normal bodily sensations as extreme danger.
Now, the sources mention a very specific term here that I want to unpack, because it sounds like something straight out of a science fiction movie.
Which one?
It's called a phenotypic switch. What exactly does that mean?
Ah, right. So a phenotype is essentially the observable characteristics or traits of a cell.
Okay.
When we talk about a phenotypic switch in the context of chronic pain, we are talking about nerves fundamentally changing their identity and their function.
Changing their identity.
Yes. In your body, you have different types of nerve fibers. Some transmit pain, but others transmit harmless sensations.
Like the feeling of a light touch, right?
Yeah, exactly. The brush of a feather or just the feeling of your clothes resting against your skin.
Right. Non-painful sensory nerves.
But under the constant bombardment of chronic pain, the nervous system alters its chemistry.
It alters its chemistry.
Yeah, these nerves that normally transmit non-pain signals can undergo a phenotypic switch. They actually start expressing something called substance P.
Oh, I saw substance P mentioned in the papers. Can we explain that, like, I'm 5? What is substance P?
Think of substance P as an emergency flare, or a chemical messenger that specifically turns up the dial on pain.
Okay, an emergency flare.
Usually only nociceptors, the actual pain nerves, release substance P when there is tissue damage.
Right.
But after this phenotypic switch, those light-touch nerves start manufacturing and releasing substance P too.
Wait, really?
Yes, they begin exciting the pain neurons in the spinal cord.
Oh, wow. So literally, a gentle touch on the arm or someone giving you a hug or even just the weight of a blanket could be perceived by your brain as agonizing, burning pain. Just because the nerves have literally changed their biological identity and are now throwing up emergency flares.
It's wild, but that is a hallmark of what the medical community calls central sensitization.
Central sensitization.
The central nervous system, the brain, and the spinal cord become so highly sensitized that the original cause of the pain often becomes entirely irrelevant.
Think about that for a second. The initial sprained ankle, the old surgical incision, the slip disc in your back, that original injury has healed.
Yep, there is no tissue damage left.
Therefore, trying to treat the ankle or the back is useless. The disease is no longer in the ankle. The disease is now residing in the misfiring of the nervous system itself.
Exactly. That shifts the entire paradigm of how we view this.
It really does. And the cascade of biological changes doesn't stop at the nerves, does it?
No, it doesn't. The sources note that this constant state of alarm causes the suppression of both cell-mediated and humoral immunity.
Let's break that down too. Immunity getting suppressed means you get sick easier.
Yes, your body is stuck in a permanent fight-or-flight stress response. It is pouring out cortisol and adrenaline.
Exhausting.
When the body thinks it's under constant attack, it deprioritizes long-term maintenance.
Right.
Cell-mediated immunity involves your white blood cells directly attacking invaders, and humoral immunity involves the antibodies circulating in your body fluids.
Okay, and both get suppressed.
Both systems get suppressed by chronic pain. You become more susceptible to infections.
Wow.
Furthermore, the constant stress causes alterations in gene expression. And perhaps most shockingly, the advanced imaging studies cited in our sources reveal a measurable loss of gray matter in the brain.
Stop right there. I want to make sure you really caught that. A loss of gray matter in the brain.
Yes.
How does being in pain literally kill brain cells?
It comes down to a process called excitotoxicity combined with massive metabolic exhaustion.
Excitotoxicity.
Basically, your brain cells, your neurons, communicate by firing electrical and chemical signals. In chronic pain, these pain pathways are firing constantly at an incredibly high rate.
They just never stop.
Exactly. And this requires a massive amount of energy.
Yeah.
Eventually, the neurons become exhausted. The constant flood of excitatory neurotransmitters actually becomes toxic to the cells.
Oh, wow.
The glial cells, the support cells in your brain that usually clean up waste, they just get completely overwhelmed.
So over years of unrelenting chronic pain, this toxic hyperactive environment leads to neuronal death.
Sadly, yes.
Right.
The brain literally atrophies in certain areas related to pain processing and emotional regulation.
That is terrifying.
Yeah.
But, it's also incredibly validating.
How so?
Well, because if the brain is physically changing, if the actual anatomy of the nerves is rewiring itself, if they're undergoing a phenotypic switch to express new chemicals,
Right.
and if gray matter is literally degenerating on an MRI, how can anyone, especially any medical professional, still look a patient in the eye and claim that this pain is all in your head?
Well, technically it is in their head.
Yeah.
Because the disease resides in the physical structure of their central nervous system, but it is absolutely not in their head. in the dismissive, imaginary, psychological way that phrase is usually used.
Exactly.
The pain is as biologically real as a broken bone or a tumor. It just exists on a microscopic neurological level rather than a macroscopic structural level.
And that profound misunderstanding is exactly where the disconnect happens.
It really is.
Because if you take a patient with a chronically sensitized nervous system, a patient whose brain has been literally altered by months or years of unrelenting pain,
Yeah.
and you drop them into a hospital environment built exclusively for acute structural trauma, you have the ultimate recipe for a systemic disaster.
Which brings us to the core of the triage trap.
Yes. Let's look at what happens in that ER interaction.
Okay.
The ER operates on a rigid, highly codified triage system.
Yeah.
When you walk in, the triage nurse assesses you based on the ABCs, right? Airway, breathing, circulation.
They are looking for immediate threats to life or a limb. That makes sense for emergencies.
But statistically, pain is the single most common presenting symptom in emergency rooms globally. The vast majority of people sitting in that waiting room are there because they hurt.
Yet, when we look at the clinical guidelines from our sources, they are incredibly blunt about how the ER views this.
Very blunt.
The guidelines state explicitly that there is, and I am quoting here, no role for ongoing routine parenteral analgesic therapy as an outpatient in the ER.
Let's translate that. Parenteral analgesic therapy means IV pain medication, right?
Yes, pain medication administered through an IV or an injection rather than a pill.
So the guidelines are effectively saying that the emergency room should not be used as a routine pain management clinic.
Exactly. If a chronic pain patient comes in because their pain has flared up to an unbearable level, the ER is structurally prohibited from just giving them an IV painkiller and sending them home.
Because that doesn't fix the underlying issue.
Right.
But the patient is sitting there at a level 10 out of 10 pain. They are desperate.
Absolutely desperate.
Yeah. If we pull back and look at the mandate of the emergency physician, their job is to find the life-threatening cause of the symptom, rule it out, and move to the next patient.
And they have, what, 15 minutes?
If they're lucky. Think about the tools the ER doctor has.
Right. They have x-rays, CT scans, and blood tests.
So when a chronic pain patient presents, the ER doctor runs the tests. The x-ray of the back looks totally fine.
The blood work is normal.
There is no acute structural damage to fix. There's no fire to put out.
The ER doctor lacks the time. They lack the specialized neurological tools. And quite frankly, they often lack the specific medical training to manage a complex, centralized pain disorder in a 15-minute consultation.
And we really have to look at the human toll this takes on both sides of the stethoscope.
Yeah, that's important mention.
The source material highlights that dealing with chronic pain takes a massive emotional toll on the clinicians themselves.
Emergency room doctors and primary care physicians report feeling deeply frustrated, ungratified, and even guilty.
It leads to a phenomenon known as moral injury.
Moral injury. These doctors went to medical school because they want to heal people. They want to alleviate suffering.
Of course.
But they are trapped in a systemic workflow that simply does not equip them to treat the very disease standing in front of them.
They have 15 minutes to clear a bed for a car crash victim arriving in an ambulance, but they have a patient in agonizing pain sitting in front of them who needs a 90-minute comprehensive biopsychosocial assessment.
It's an impossible situation, and it leads to a complete breakdown of the patient-clinician relationship.
Totally. In that rushed emergency department setting, patient autonomy and doctor autonomy clash violently.
The patient is desperate for relief. They know from their own lived experience that their pain is severe, it is real, and it is destroying their life.
While the doctor, meanwhile, is trained to be highly cautious.
Especially with pain medications, yes.
And they're looking at a patient with no visible objective signs of acute injury.
This breeds an environment of profound mutual suspicion. The patient feels like the doctor doesn't believe them. The doctor worries the patient might be exaggerating for drugs. It's a toxic dynamic.
And we must address the very difficult reality that this suspicion does not fall equally on all patients.
No, it certainly doesn't.
When we look at the data provided in these sources regarding systemic disparities in pain management, the numbers are incredibly sobering.
They are. The ER environment, with its high stress, its rushed decisions, and its lack of objective tests for chronic pain, seems to act like a pressure cooker that exacerbates existing unconscious biases.
What do the statistics actually show on this?
The medical journals analyzed studies spanning from 2015 to 2017, and they found significant racial and demographic disparities in how pain is treated.
Okay.
For example, the data showed that Hispanic and Asian patients receiving emergency medical services treatment were actually less likely to even receive a basic pain assessment procedure compared to white patients.
Let's pause and really think about what that means in the human context.
It's hard to hear.
A patient is in the back of an ambulance or in a triage bed in severe pain, and the medical professional doesn't even ask them to rate their pain on a scale of 1 to 10.
No. They don't even perform the basic assessment required to start treatment.
It is a failure of care at the very first step.
And the data also shows that people of color are significantly less likely to be prescribed appropriate pain medication, and they consistently report feeling less heard and less taken seriously by their clinicians.
Wow.
Furthermore, the sources point out that LGBTQ+ patients report higher levels of chronic pain generally across their lifespan, and alarmingly, they report instances of being refused medical care altogether.
We want to be very clear here. We are looking strictly at the data presented in the medical journals.
Yes, just impartially looking at the numbers.
But the data tells a story of a massive systemic failure. If pain is the #1 reason adults seek medical care globally, shouldn't our frontline healthcare system be better equipped to handle it without these glaring disparities?
You would think so.
Why do these biases flourish in the ER?
Well, it comes down to how the human brain processes information under extreme stress.
Okay, tell me more about that.
When doctors and nurses are rushed, overworked, and forced to make rapid-fire decisions without clear, objective data like an X-ray showing a broken bone, they unconsciously fall back on heuristics.
Heuristics are mental shortcuts, right?
Yes, and unfortunately, those shortcuts are often shaped by societal biases and systemic protocols that marginalize complex cases.
So it's not necessarily conscious malice, but a flaw in how the system forces human beings to operate.
Exactly, but the result for the patient is the same.
Right. When a patient senses that bias, when they feel that suspicion from the doctor, they shut down.
Naturally.
They might withhold vital medical information out of fear of being judged. They might not mention other alternative treatments they are trying.
And the doctor, picking up on that closed-off demeanor, views the patient through an even heavier lens of skepticism.
The result is a total collapse of effective medical care.
The patient is discharged, and they leave the ER not only still in physical agony, but now carrying the heavy psychological trauma of being invalidated, dismissed, and profiled by the very people supposed to help them.
And that psychological trauma is not just a secondary side effect. It is not just feeling bummed out about a bad doctor's visit.
No, absolutely not.
That emotional distress actually feeds the physical disease.
Yes, it does.
Which brings us to the next critical piece of this puzzle diagnostic overshadowing and the mind-body feedback loop.
This is a huge concept.
We've already established that physical pain literally changes the brain. But the emotional distress that follows an ER visit actually makes the physical pain worse.
It does.
I like to picture it like an acoustic feedback loop.
Like a microphone and a speaker.
Exactly. You know when someone is giving a speech and they hold a live microphone too close to a monitor speaker on the stage?
Oh, yeah, you get that high-pitched, deafening screech.
Exactly. The microphone picks up a tiny sound, sends it to the speaker amplifies it. The microphone picks up the newly amplified sound, sends it back to the speaker, which amplifies it again.
Right, and it happens in a fraction of a second.
And it just builds and builds until the noise is unbearable and you have to cover your ears. That is exactly what happens between physical chronic pain and psychological distress.
That is a brilliant analogy. The medical literature refers to this as a bidirectional link.
Bidirectional link, okay.
Psychological distress is not just a result of pain, it is one of the prime mediators and amplifiers of chronic pain.
Wow.
And the data from our sources on this link is staggering. To prove this isn't just a coincidence, the researchers use something called Mendelian randomization studies.
Okay, hold on. Let's explain Mendelian randomization like I'm 5, because that sounds incredibly dense.
It does, but it's actually a really cool genetic tool used to prove cause and effect.
Okay, how does it work?
Normally, in a study, you might see that people with depression also have chronic pain. But you don't know which caused which, or if it's just a coincidence because they both, say, eat the same diet.
Right, correlation versus causation.
Exactly. Mendelian randomization looks at your genes, the genetic hand of cards you were dealt at birth, before life experiences happen.
Oh, I see.
It looks at genetic markers known to cause depression and sees if those specific genetic markers also lead to chronic pain later in life.
So it acts like a randomized controlled trial naturally built into our DNA.
Yes, so it proves it's not just a coincidence, it proves a biological link.
Oh, wow.
And these studies show that having major depressive disorder, or MDD, increases the risk of developing chronic regional pain by an odds ratio of 1.26.
An odds ratio of 1.26, meaning a person with depression has a 26% higher chance of developing chronic physical pain.
Yes, and it works the other way, too. Having multi-site chronic physical pain increases the risk of developing major depressive disorder by an odds ratio of 1.88.
An 88% increased risk.
The two conditions are constantly feeding into each other, increasing the likelihood and the severity of the other, the microphone and the speaker.
When you look at psychiatric populations, the prevalence of chronic pain is off the charts.
It really is.
In the general population, chronic pain affects roughly 20 to 25% of people, which is a huge number on its own, 1 in 4 people.
Yes.
But in patients diagnosed with major depressive disorder, the prevalence of chronic pain shoots up to between 53 and 65%.
And in patients with post-traumatic stress disorder, PTSD, an astonishing 88 to 96% report experiencing chronic pain.
Almost every single person with PTSD is also living with physical chronic pain.
And this profound overlap raises an incredibly dangerous question about how the medical community views these patients. Enter the concept of diagnostic overshadowing.
Let's unpack that. Diagnostic overshadowing.
This is a deeply problematic phenomenon in medicine where a patient's legitimate, biologically real physical pain is entirely dismissed by healthcare providers as merely a manifestation of their psychiatric illness.
So a patient walks into the ER. The doctor looks at the patient's electronic medical chart. They see a history of severe anxiety or depression or PTSD.
Yes.
And instead of looking at the physical symptoms presenting that day, the doctor's brain takes that heuristic shortcut we talked about. They automatically assume the pain is just in their head.
Exactly. The doctor attributes the physical complaint entirely to the mental illness.
Just ignoring the physical entirely.
Right. They treat the pain as a purely psychological issue, entirely ignoring the neuroplastic changes, the central sensitization, the substance P, and the real physical agony the patient is enduring.
The psychiatric diagnosis overshadows the physical diagnosis.
It's a huge problem.
And imagine what that does to the patient's behavior. The behavioral toll of this loop is devastating. The literature talks extensively about a condition called kinesiophobia.
Kinesiophobia, yes.
Let's break that word down. Kinesio means movement. Phobia means fear. Kinesiophobia is the intense fear of movement.
It makes complete logical sense from the patient's perspective, honestly. When it hurts intensely to move, your natural evolutionary instinct is to stop moving.
Yeah, you want to protect the body. If walking hurts, you sit. If sitting hurts, you lie down.
But because chronic pain isn't an acute injury that needs resting, because there is no broken bone that needs to be immobilized, staying still is actually the worst possible thing you can do for your body.
It is catastrophic. When a patient stops moving due to kinesiophobia, their body rapidly deteriorates.
The muscles begin to atrophy and lose mass. The fascia, the connective tissue wrapping around the muscles, becomes stiff and rigid.
The joints lose their lubrication. Cardiovascular stamina plummets.
And this massive biomechanical deconditioning leads to, you guessed it, even more physical pain when they inevitably have to move.
It creates a prison of inactivity. And it's not just a physical prison.
No, it affects everything.
As the patient withdraws from physical activity, they naturally withdraw socially. They can't play with their kids on the floor. They miss days of work.
They cancel plans with friends, they miss family weddings, they isolate themselves in their homes.
And human beings are deeply social creatures. This enforced isolation breeds profound feelings of hopelessness.
The patient feels a total loss of their identity and self-worth. They feel like a burden to their family.
This deepens the depression, which, as we know, amplifies the physical pain signals in the brain. The feedback loop gets louder and louder.
Which leads to the most tragic statistic in this entire stack of research.
It is a statistic that should stop every healthcare administrator in their tracks.
Absolutely.
When you combine the unmet treatment needs, the constant dismissal and diagnostic overshadowing by the medical system, the relentless physical agony of the sensitized nervous system, and the crushing social isolation.
It leads to a lifetime prevalence of suicide attempts in people with chronic pain ranging from 5% to 14%. Let that sink in for a moment.
Up to 14%.
Yeah.
More than 1 in 10 people living with this disease reach a point where the pain and the isolation are so unbearable, and the medical system has failed them so completely that they attempt to end their own lives just to escape the feedback loop.
It is a devastating failure of public health. We're failing millions of people.
We really are.
And while human suffering should always be our primary metric, the economic cost of this failure is also astronomical.
Let's hear the numbers on that.
In the United States alone, the annual cost of chronic pain combining direct medical expenses and the massive loss of workplace productivity is estimated at $560 to $635 billion.
That is more than the annual costs associated with cardiovascular disease, more than diabetes, more than cancer.
Yet chronic pain does not receive even a fraction of the funding, the research grants, or the clinical priority of those other diseases.
Because it is misunderstood.
Exactly. Treating chronic pain as either a purely structural, surgical issue like fixing a bone, or treating it as a purely psychological issue like just giving them an antidepressant is doomed to fail.
The disease exists in both realms simultaneously. It must be viewed and treated through a biopsychosocial lens. Biological, psychological, and social.
Right.
So if a patient realizes the ER can't fix their broken smoke detector, and the psychological feedback loop is getting louder, and the physical pain is unbearable, what do?
When you're desperate, you look for the absolute fastest, most powerful mute button available.
And for decades, the medical system handed them that mute button opioids.
Yes.
This brings us to the most heavily debated and misunderstood trap in modern medicine. The opioid pendulum.
We have to look at the history here to understand the trap. Opioids are, without a doubt, highly effective medications for acute pain.
We talked about the ER extinguishing fires.
Yeah.
If you shatter your femur, an IV opioid like morphine or fentanyl in the emergency room is exactly what you need.
Yes.
How does it work on a biological level for acute pain?
Opioids work by mimicking the natural pain-relieving chemicals your body produces, like endorphins. The drug enters your bloodstream and travels to the central nervous system. There, it binds tightly to specific proteins called mu-opioid receptors, which are located on the nerve cells in your brain and spinal cord.
Mu-opioid receptors.
Yes. When the opioid binds to the receptor, it acts like a massive roadblock. It blocks the transmission of those nociceptive pain signals from reaching the brain. The brain simply stops receiving the danger messages.
Because they work so incredibly well for acute pain, and because ER doctors and primary care physicians were desperate for a tool to help chronic pain patients, a massive systemic over-reliance on opioid medications developed starting in the late 1990s.
The system essentially said, well, if it works for a broken leg, let's just give it to the person with chronic back pain every day.
But the sources reveal a stunning, almost unbelievable gap in the medical evidence behind that decision.
It's hard to even wrap your head around.
We used opioids as the gold standard for chronic pain for years. We prescribed them by the millions. But the systematic reviews cited by current clinical guidelines identify absolutely no randomized trials of opioid therapy that report long-term benefits for chronic pain.
None.
Let me repeat that. No evidence of long-term benefits for pain reduction, no long-term improvements in physical function, and no long-term improvements in quality of life. None.
The mute button eventually stops working because the body is remarkably adaptable. When you bathe the brain in exogenous opioids from outside the body for a long period, the brain realizes it has too much of the chemical.
Right.
So it downregulates its own natural receptors. It becomes tolerant. You need a higher and higher dose to get the same pain relief.
And even worse, long-term use can lead to a paradoxical condition called opioid-induced hyperalgesia, or OIH.
Yes.
Hyperalgesia, meaning extra sensitive to pain.
Yes, the nervous system fights back against the drug by actually creating more pain pathways. The drug that was supposed to kill the pain begins to actively make the baseline pain worse.
If the science shows they don't work long-term, and they actually make things worse, why were we flying blind for so long? Why weren't there massive studies proving this decades ago?
It comes down to a profound ethical dilemma inherent in clinical trials.
What kind of dilemma?
To get true, reliable, long-term data on the efficacy of any drug, the gold standard is a randomized, placebo-controlled trial. You need to follow two groups of patients for months or years. One group gets the real drug, the other group gets a sugar pill.
But you can't do that with severe pain.
Exactly. Ethically, you cannot take a control group of human beings who are suffering from severe, debilitating, suicidal chronic pain and give them a sugar pill for 2 years just to see what happens.
That would be incredibly cruel and a huge violation of medical ethics.
Because of these constraints, most drug trials for pain medications are very short, maybe a few weeks or months. Thus, the medical community was essentially flying blind, extrapolating short-term acute pain data to justify years-long prescriptions for chronic pain.
And we all know the devastating results of flying blind.
We do.
That historical over-reliance, pushed heavily by pharmaceutical marketing, led to alarming, tragic increases in drug diversion, overdose deaths, and addiction.
It created the opioid epidemic, which has ravaged communities across the globe.
But now, in response to that epidemic, the pendulum has swung violently in the exact opposite direction.
Current clinical guidelines now strongly discourage opioid prescribing for chronic non-cancer pain.
The regulations are incredibly tight now.
Physicians are terrified of being audited by the DEA or losing their medical licenses. The guidelines have left them confused, defensive, and hesitant about whether, when, and how to prescribe these medications without increasing public health risks.
And who suffers the most from this violent pendulum swing? The patients.
The patients always suffer the most.
We have millions of patients who were medically managed on opioids by their doctors for years or even decades. Their bodies have developed a deep physiological dependence on the drug.
And we must clarify, physiological dependence is not the same as the disease of addiction.
Important distinction.
Dependence simply means the body has adapted to the presence of the drug and will suffer physical withdrawal if it is suddenly removed.
While addiction involves compulsive use despite harmful consequences.
Right. Many chronic pain patients are dependent, but not addicted.
But the new policies often don't care about that distinction. Patients are finding themselves abruptly cut off from their prescriptions as doctors try to clear their patient panels of opioids.
And when these desperate patients who are now experiencing a severe pain flare-up compounded by terrifying physical withdrawal symptoms go to the ER,
They step right back into the triage trap.
only this time it's worse. They are no longer treated as patients in pain. They are heavily stigmatized, profiled, and frequently labeled in their charts as drug seekers.
It is the ultimate systemic paradox.
Truly.
The medical system essentially trained chronic pain patients to rely on a specific medication because it was the only tool the system offered.
They didn't offer complex multidisciplinary care because it was too expensive. They offered a pill.
And the pill doesn't fix the underlying central sensitization. It doesn't reverse the neuroplastic changes in the brain.
Nope.
And now, the very same medical system is punishing the patients for that reliance, abruptly cutting them off, and offering almost zero accessible alternatives.
The discrimination is palpable. The sources note that fear of dependence makes doctors reluctant to prescribe even short courses of painkillers for severe chronic flare-ups.
And patients with any known history of substance abuse are particularly discriminated against, right?
Oh, massively. If a patient is in recovery, their legitimate physical pain is often entirely ignored because the doctor's too afraid to treat them.
It creates an impossible situation. I mean, we absolutely must acknowledge that the risk of opioid abuse and overdose is a massive, deadly public health crisis.
Absolutely. No one's debating that.
But the abrupt, systemic shift in policy, without a corresponding massive increase in access to alternative, holistic pain management programs, has left millions of chronic pain patients abandoned in the gap.
They are caught in a system that says, we can't give you the pills anymore, but we also won't pay for the comprehensive care you actually need.
So how do you actually get out?
That's the million-dollar question.
If the ER is a trap built for acute fires and opioids are a flawed, long-term tool that the system is taking away anyway, how does a person escape this cycle? How do you get out of the triage trap and find real, lasting relief?
Let's talk about the new multidisciplinary paradigm.
Because the sources are very clear escaping, the trap starts with a massive psychological shift in expectations.
And that shift is perhaps the hardest part of the entire journey for a patient.
Why is that?
For acute pain, the goal is always a cure. You fix the broken bone, you stitch the cut, pain goes away entirely, you go back to 100% normal.
Right.
But for chronic pain, because it is a complex disease of the nervous system, because the brain has physically changed, the goal must shift from eradicating the pain completely to managing the pain.
It's moving from turn the pain off to learn how to turn the volume down so I can live a full life anyway.
Exactly. The objective is functional and emotional restoration.
It is about improving the quality of life, regaining the ability to engage in daily activities, going back to work, playing with your kids, even if a baseline level of pain remains in the background.
It is about taking the microphone away from the speaker so the feedback loop stops screeching.
And you cannot achieve that massive life shift in a 15-minute ER visit.
Impossible.
Optimal management requires a holistic, multidisciplinary team. We are talking about pain medicine specialists, behavioral therapists, physical therapists, occupational therapists, and social workers, all communicating and working together on a single patient's case.
It's the full biopsychosocial approach.
The evidence for this approach in the literature is robust. When we move away from solely relying on pharmacology, we see incredible results.
The sources highlight several proven interventions, actually. Cognitive behavioral therapy, or CBT, is a cornerstone of this.
Now, I know some listeners might roll their eyes at CBT for physical pain. They might think, oh, they just want me to think happy thoughts so my back stops hurting.
Right, but that's not what CBT is doing at all.
It's much deeper than that.
But much deeper. CBT is not about pretending the pain isn't there. It is a structured psychological intervention that directly attacks the kinesiophobia we discussed earlier.
How does it do that?
It uses the concept of neuroplasticity, the brain's ability to rewire itself.
Okay.
CBT helps patients identify catastrophic thought patterns, like, if I walk to the mailbox, I will paralyze myself.
Oh, I see.
By challenging those thoughts and slowly, safely reintroducing movement, CBT actually rewires the neural pathways in the brain. It lowers the threat level, it turns down the substance P.
It breaks the cycle of fear and avoidance so the body can start physically reconditioning.
Yes.
That makes so much sense. It's retraining the broken smoke detector to recognize that there is no fire.
And the sources also point to body-based interventions like yoga and Tai Chi.
Yoga and Tai Chi. Now, these aren't just about stretching, are they?
No, not at all. Yoga and Tai Chi incorporate deep, rhythmic breathing and mindful movement. This specific combination is proven to trigger the parasympathetic nervous system.
Which is the rest and digest mode of your body.
Exactly. This directly counters the sympathetic nervous system's fight-or-flight overdrive that chronic pain causes. It lowers cortisol, reduces muscle tension, and soothes the hyperexcitable nerves.
The data even highlights that combining therapies, such as using acupuncture alongside appropriate non-opioid medications, yields significantly better long-term functional results than medication alone.
But here is the brutal reality check.
Yeah.
Getting access to this dream team of multidisciplinary care, having a therapist, a physical therapist, and a pain doctor all working together is incredibly difficult for the average person.
Then why is that?
Because of a massive structural bureaucratic barrier. The sources note that outside of highly specialized private pain clinics, chronic pain has historically had a very low priority in healthcare systems globally.
To understand why, you have to look at how medical bureaucracy works.
Yes.
For a long time, chronic pain didn't even have a specific World Health Organization ICD code.
Right.
An ICD code. Let's explain what that is, because it dictates everything in healthcare.
The International Classification of Diseases, or ICD, is a global system of diagnostic codes.
Okay.
Every specific disease, injury, or symptom has a code. It is the language of healthcare. When a doctor sees you, they enter an ICD code into the computer.
Right.
That code dictates health statistics, it dictates government research funding, and most importantly, it is the only way a doctor gets paid by an insurance company.
So if chronic primary pain didn't have a specific code,
It meant the disease officially did not exist in the eyes of the bureaucracy.
you were an invisible ghost in the system.
Basically, doctors couldn't easily bill for the complex 90-minute multidisciplinary assessments required to treat it.
And if a disease isn't adequately remunerated by insurance companies, hospitals won't build clinics for it, and medical schools won't prioritize training specialists for it, it doesn't get political backing or funding.
Wow. It's a cascade effect.
And without that institutional recognition, primary care doctors and general practitioners are left completely under-resourced.
They want to refer you to a specialist, but there are no specialists to refer you to.
We have a widespread systemic shortage of pain specialists. In the UK, for example, the sources note there is only one pain specialist for every 32,000 people living with chronic pain.
That is a staggering bottleneck.
32,000 to 1. It means that to escape the trap, a patient cannot rely on the system to simply rescue them.
No. Patients are forced to become relentless, educated advocates for their own care.
And that is exhausting when you are already in pain.
It is, but it is the reality. So how does a patient actually advocate for themselves in a broken system?
What can they do?
It requires a fundamental shift in how you interact with your primary care doctor. You have to move away from the passive, old school doctor, please fix me model.
Right?
You have to move to a shared decision-making model where you act as a partner in your own healthcare.
One of the most practical steps highlighted in the clinician handbooks we reviewed is creating something called a pain flare-up plan.
Yes, and you have to create this plan before the pain gets unbearable.
Right, because when your pain spikes to a level 10, your brain is in panic mode.
You cannot think clearly. You will naturally default to calling an ambulance or driving to the ER.
Exactly. So a flare-up plan is a written document you create with your primary care doctor on a good day. You establish exactly what steps you will take when the pain spikes.
What does that plan usually look like?
It includes specific instructions, like what non-opioid medications should you take immediately? What specific stretching or breathing exercises should you initiate?
Who is your emergency contact? And most importantly, is there a direct hotline to your pain clinic or primary doctor that you can call to bypass the ER entirely?
The entire goal of this written plan is to give you a roadmap so you don't end up sitting in that harsh fluorescent waiting room at 2 a.m.
Furthermore, when you do have appointments, patients need to explicitly demand care that addresses all three facets of their suffering.
The biological, the psychological, and the social.
Exactly. Don't let a doctor just look at your back x-ray. Make them talk to you about your kinesiophobia and your depression, too.
Well, let's summarize the incredibly deep journey we've been on today. If you take away anything from this deep dive, let it be this. Chronic pain is not just a symptom that overstayed its welcome.
It is not an ankle sprain that is taking a long time to heal.
It is a severe physical disease that literally changes the anatomy, the neurochemistry, and the wiring of your brain.
And the emergency room is a brilliant triage center built to put out acute, life-threatening fires.
But because of its rushed nature, its lack of tools, and its reliance on heuristics, it is fundamentally mismatched for the complex long-term care that chronic pain requires.
The historical reliance on opioids was a trap born of desperation, a lack of long-term data, and systemic neglect.
Escaping that trap requires abandoning the search for a magic cure-all pill. Instead, the only true way forward is demanding and embracing a holistic, biopsychosocial approach that treats the mind and the body together.
And to the listener navigating this right now, perhaps sitting in pain as you listen to this, your pain is real.
It is real.
It is not imagined. It is not a character flaw. And it is certainly not a psychiatric illusion. The neuroplastic changes, the central sensitization, the substance P in your nervous system, these are documented, undeniable scientific facts.
Understanding the biology of your pain, recognizing that your internal smoke detector is broken, but there is no fire, is the crucial first step in reclaiming your life, your function, and your joy from this disease.
It changes everything when you realize you aren't crazy. Your alarm system is just misfiring.
Exactly. And that realization actually leads to a rather profound thought about the future of medicine.
Oh.
We know that neuroplasticity works in both directions. The brain learned to be in pain, which means the brain can theoretically unlearn it.
That's a fascinating concept.
If chronic pain fundamentally alters the brain's gray matter, and if the disease is rooted in the physical wiring of the nervous system, could the future of pain medicine lie not in developing stronger, more dangerous painkillers, but in therapies that literally erase the brain's memory of the pain?
Erasing the memory of pain.
Yes. Researchers are currently exploring the concept of memory reconsolidation. If the brain can learn this maladaptive pain state, can we use targeted therapies, perhaps advanced neurostimulation, or even carefully controlled pharmacological interventions paired with intense therapy to force the nervous system to reboot its broken smoke detector?
Can we wipe the slate clean and teach the nerves to forget the pain entirely?
Now that is a thought to leave you with. Until next time, keep diving deep.